Okay, so welcome to our conversation on the challenges and opportunities in Africa's health systems. My name is Lindsay Farrell, and I'm a senior lecturer in anthropology and a director of the Africa program at the Lauder Institute. I'm joined today by guest experts who will help us understand the unique challenges and opportunities in healthcare in Africa. This conversation is contributing to a series we will be hosting this fall at the Lauder Institute. Our main goal is to speak to contemporary and timely issues on the continent by connecting with academics and practitioners who can help us to frame and contextualize realities on the ground. In light of the challenges that have been presented by COVID, we want to take a step back and fully understand what is the overall reality of health institutions in Africa today. So our guests were to be people that mainly work in the East Africa region, Tanzania, Kenya, and South Sudan. So the caveat was that the realities and the situation in other parts of Africa may look different, but with the addition of Steve, perhaps we can get some context from other regions, although I think you've mainly worked also around the Nairobi ecosystem. So in light of this, I think I'm going to have you introduce yourselves so that I make sure to get both of your backgrounds, and then we'll just open it up to, as you introduce yourself, if you could just start with a conversation that, you know, speaks to from the vantage that you sit, what are the opportunities and current challenges of health systems, just the institutions of health as you currently see them. So Noelle, please introduce yourself, and then you can make your comments.
Sure, thank you for having me. I'm Noelle Sullivan. I am an associate professor of instruction in global health studies at Northwestern University. And I've been looking since 2008 really at sort of how interventions that are planned from outside and even inside the Tanzanian health system, how those end up playing out on the ground, what it is that different parties are doing to try to improve healthcare. And that spans the gamut from just individual international volunteers that go through like some sort of for-profit company for a placement for 2 weeks, all the way to big interventions by USAID or the Global Fund or those kinds of things, and what does it mean for the health system and for individual health institutions, both primarily public, but also some missionary ones that get some public funding. I imagine, I think there's a lot of challenges. One of the ones that I've been really tracing is the fact that a lot of the interventions that are planned by outsiders don't really apply to the needs on the ground of the institutions where they're implemented. And a lot of times there's a lot of dumping that occurs as well, where people will be bringing in equipment or bringing in drugs or this kind of thing that are actually just not appropriate to the context. And meanwhile, a lot of these institutions have put together 5-year plans of what they would like to build and what they would like to work on in terms of capacity. And they're not garnering a lot of attention from either donors or the private sector, or even, you know, just individual volunteers that are coming through who sort of want to pursue their own ideas on what they think needs to happen when they don't really understand that context very well. So that's sort of what I do. And I think there's a lot of opportunities that could arise if there was much more of a centering of context and of the people that are on the ground that actually know what it is that they need. I have a lot of stories about those things to tell, but I think I'm gonna popcorn it over to Steve so that you can introduce yourself and we can have more of a conversation.
Thank you, Noelle. And actually, it was quite interesting to hear. I'll go so far as to say your diagnosis as to what often goes wrong with the implementation of strategies in African health. I came on to be just an observer today, so I haven't prepared anything at all, but I'll just speak off the cuff. I am a senior fellow in healthcare management and a lecturer also at Wharton in both the healthcare management department and in the management department. And among the things I teach in healthcare is a course called The Role of the Private Sector in Global Health. and we cover a lot of these issues. I've been teaching at Wharton. This is my 29th year of teaching, but during all those years, teaching has been a portion of my professional time, and the other half has been private equity and venture capital. And most of that has been in biotechnology, and in recent years, health services. And going back to, it's nearly 20 years now, I shifted from a US focus to an international focus, and that's centered at first on India and then on Africa. When I started doing work in Africa, one of the things that became very obvious is that there's a horrific scarcity of well-trained managers, not only for pharmaceutical companies and things like that, but also for hospital administration. And I was introduced to the dean of the Strathmore Business School in Nairobi, Kenya. And after a conversation in which I told him about what we were doing in India in setting up a healthcare management program, he asked if I would help him set up a program there. And I immediately agreed. That was 2011. And in 2013, we launched the first healthcare management MBA program on the continent. And unfortunately, it's still the only one. We are almost certainly going to be expanding into Ghana in collaboration with another university. We've now run over 300 students through that MBA program, and they're working primarily in Kenya, but also Uganda, Nigeria, and Rwanda. So our footprint has expanded quite a bit. A few years ago, interestingly, this is a Lauder Institute event. I was asked by Mr. Ronald Lauder if I would work with him and his dear friend Richard Parsons with their African-focused activity, the main one of which was a private equity fund called Alta Semper, which was essentially founded by a Wharton grad named Afsani Jetha, who is native-born Tanzanian. Our family is sixth generation Tanzanian. And she has put together an extraordinary team, a number of Wharton grads on the team, to focus on healthcare and food security in Africa. And in fact, we've now made 3, very soon 4, and not long after that, 5 investments. Now we have the largest cancer care program or center in Africa. It's based in Morocco. These are all for-profit businesses. We have the largest chain of retail pharmacies in Africa, based in Nigeria. We have a specialty pharmaceutical company based in Cairo, and soon a food security company also in Cairo. We're working in the area of diagnostics and the like. So in addition, I spend a lot of time with governments. I think the game changer in Africa is going to be the adoption of universal health coverage. And that will make a massive difference in how things work. So that's my story.
Thanks, Steve. I'm seeing Moka landing, but he hasn't turned his video on. So we'll wait for him to do that. And while he does that, and because you brought up government, I want to pull up. Here he is. Moka, hello.
You're on mute, Moka.
Hi, my sincere apologies for running way behind schedule.
Okay, we've had a little bit of hiccups this morning. We've actually invited one of our colleagues, Steve Sammut, who has done a lot in the healthcare industry, to join us in your absence, but we're going to make this work. And then Noelle Sullivan is a professor at Northwestern University who works in public-private partnerships, all we've done is introduce ourselves and say what are sort of what we're seeing right now, what are the challenges and opportunities that we're seeing in healthcare. So I'm going to let Dr. Moka Lantum introduce himself.
Well, in the interest of time, I would keep it brief. Good morning, everyone. Thanks, Lindsay, for inviting me. Always appreciate the invitation. In a nutshell, I just describe myself as a hustler. And I use that word intentionally because the nature of business or startup in the Africa setting borders on being crazy or insane or insanity and the dream of every entrepreneur in the world. There is a dream of entrepreneurship and there is insanity. And I think in the African market, we are in somewhere in between. And that's why I use the word hustler. Why? Because, we are launching businesses under very extreme conditions, no clear channel strategies, financing opportunities are very difficult to come by. The market data is very difficult to understand and appreciate. Talent development is not a walk in the park. And so, and then we are always competing with external forces, be it because of public policy, be it because of lack of regulations. So in a way, it is the Wild West. And so it makes it exciting, but I'll tell you that it is one of the most difficult challenges you could ever undertake. And so our company, we focus on getting medicines to people at the fastest rate, at the cheapest price, and of best quality. And that requires us disrupting the market using technology so that the premium private facilities that are commanding the market, we give them the run for their money by showing we can disrupt the market and make healthcare more equitable for particularly low-wage workers who form 75% of the workforce, but many of them till this day cannot afford either a private insurance cover or even care in a decent facility. We've been in the market now for with a new product since 2016. And so I'm very happy to share with you our journey, how we've threaded the needle and what it takes to stay alive, including emergency calls that make you late for Zoom calls.
Okay, great. Great. So we have, the reason that I kind of compiled this panel is because I wanted to get the hustler perspective of what it's like to actually try to build something, the perspective that Noelle brings, which is what we were talking about before, 15 years of observation of this one hospital in Tanzania that apparently I've been to, but I don't remember going to. And with Steve and Wilmot, this perspective of what's actually going to make people money, what's actually like going to be scalable, what's actually feasible and possible in terms of the financing and the availability or the will to make some of these basic realities possible. Hey, look at this. Everybody just keeps popping in. Hello, Wilmot. How are you?
Hi, everyone. I'm well. Good to see you.
Because you're here, I'm going to have you introduce yourself, and then I'm going to ask my next question. Can you introduce yourself and just share very briefly some challenges and opportunities that you see in the health sector today?
Great. Greetings, everyone. Wilmot Allen from Nairobi, Kenya. I am based here where I do a couple of things in healthcare. I'm focused on my role as a venture partner with a private equity fund. It's based in South Africa. This is the third fund. It's RH Africa Fund 1, RH Fellow, RH Managers is the company. And also have been involved with the Africa Union CDC in their effort to roll out a new foundation called the Africa Public Health Foundation, which is their primary COVID-19 response and primary institutional response for strengthening healthcare systems across the continent. And so I think I just said what the challenges were: strengthening healthcare systems across the continent. And that really is writ large, from the professional technical team to resources and equipment, to responding to pandemics like the one we're in now. So it's holistically underserved. And the good thing is there are a lot of resources now being mobilized. And I think the challenges on top of that is coordination and efficient collaboration, now that so many resources are being focused on Africa healthcare systems. I think strengthening the research centers, institutional capacity to take on research and train staff is very, very important, which is the great work that Dr. Sammut is doing at Strathmore. And yeah.
Thank you so much. Okay, great. So let's get down to the nitty gritty of, and I think this is perhaps something that Noelle, Moka, I know the work you've done in rural parts of Africa, maybe this, Wilmot. Can you speak to the potential or possibility for public institutions to be bolstered? So Noelle's most recent work has been on, can there be sort of a private public partnership to bolster public health institutions? Is the public sector, the public health institution, salvageable, or should we be moving towards some other solution? And specifically, when we're thinking about rural Africa, which now, you know, it's an urbanizing continent, but still the majority of Africans are living in rural places. How do we manage some of the major gaps that are happening in rural places? Noelle, do you want to start?
Way to throw me an easy one. The vast majority of I'm really interested in how big changes in funding and policy and investments and things, how they play out on the ground. And I've been working primarily in one institution because it gives me a really nice longitudinal perspective and change through time in one institution. But I've also got 5 other health facilities. They're all in Arusha region in northern Tanzania, where I've been looking at these kinds of things too. And interestingly enough, a lot of these public or publicly funded institutions, because some missionary facilities also get public funding, have been trying to figure out how to increase their financing, right? Finance for the pressure in Tanzania for sure. And there's been a lot of experimentation. I really love this idea of hustling that Moka brought up, because actually another paper that just came out this year is called Hospital Side Hustles. It's all about these sort of business generating side hustles that these facilities are trying to take on. And I think the challenge, like, I think it is very salvageable, but the decisions about what the health sectors are going to do in the public sector are often being decided in conference rooms in big cities, very much outside of the places where these challenges are occurring. And the priorities are often set at the transnational level, with the requirement, for instance, that everybody demonstrate that they're moving towards the Sustainable Development Goals. And how do you even measure that becomes really challenging, because every donor that comes into an individual facility wants you to track everything that you're doing in their program, and then the public sector wants you to track what they're doing in their sector. And it's like there's more apps, there's more constantly more data generation, and most of the people working in the ground don't see how any of that helps them at all. You know, they've got an interest in providing healthcare to people, and they're navigating a lot of shortages, and that's more work without more compensation. And then there's just politics that occur within individual institutions that aren't planned for at those sort of national and transnational levels, or with private investments. So just thinking about poor management skills, again, that was brought up. The really talented managers that I have seen working where they're able to get a particular department really working efficiently, the people that work underneath them with the least amount of education also have the longest standing ties to the community and to people who are elected officials in that community. And they are very efficient at getting people that are really good managers transferred out. So there's that also sort of component of things about like what's the culture of a given institution and how do you put accountability in place with that kind of setup in what was beautifully referred to as, you know, hustling, right? And a lot of these hospitals are hustling too. So if you'll forgive me, two quick examples I have. One is one of the public hospitals, publicly funded hospitals that I encountered had started a wedding gown rental business out of the palliative care unit, where they were trying to generate additional income by renting out wedding dresses that they had shipped in from Europe, because this is a new thing in the area. It's become really popular. And this is what the palliative care nurse was now doing, is she's no longer providing palliative care. Her unit is now filled with wedding dresses to rent out to the community. And a second one was a kind of a public concept of doing a private concept of doing a very, very high quality private hospital catering to middle and upper class folks, and using the profits from that in order to fund healthcare services to a missionary hospital that primarily dealt with primarily Maasai folks that didn't really have any money. And so it was much more of a charity-based organization. And they also had problems with financing, even though they were attracting a very wealthy clientele. And, you know, I think everyone's trying to figure out this problem. And I think given the willingness, at least in Tanzania, the government opened a space where public institutions were allowed to seek out their own partnerships and their own initiatives. But the more remote that facility is, the harder it is to even find partners. So the fact that there's all this interest in even trying things out is really positive. But how do you attract attention for those particular issues?
Yeah, I want to move to Moka. So from that really base level, nice anthropological, ethnographic level, Moka, do you have any response to how do we reach these people? You've been at this puzzle. How do you solve some of those issues?
Lindsay, this is a very thorny issue, and I'll try to be brief and be as direct as I can on the subject, because I think it is one of those topics that make people very uncomfortable in global health. I think Wilmot would back me up on this. When you're talking about private enterprise, you're trying to ask three questions. Who is your customer? What is your forecast? And what is your return on investment? Now, let me triangulate those three basic questions. Obviously, there are many other questions, but let's just start with those three questions for a minute. From the view of public, who is the customer? The customers are the voters. That is who they are doing everything for. It is for local policy. It is not really to make people get, there's very little value that a public system brings besides trying to get and retain voters. That is why resources come in before elections and then they disappear shortly thereafter. Secondly, the forecast in the public system is solely and entirely based on who do you know in that administration. And so as soon as the next administration comes in, your business starts from scratch. That is public sector business at its core. I know people who made a lot of money when the last administration was there, now they come in. So there is no way to forecast any growth in the public sector besides who do I know. And if my uncle is the next governor, bet you I'll become a healthcare entrepreneur and I'll be successful for the next 4 years until his nemesis takes over. And then my business is done. Lastly, the effectiveness. Now we are in business, and I really want to kind of drive this message very as strongly as I can. Entrepreneurship is about the effective use of resources to reach the highest number of people in the shortest time possible. We are managing time, treasure, and talent. Public systems, just the notion of procurement alone, it takes 3 months to buy syringes. Right now, for COVID testing, it is taking 6 months, even in a crisis, to decide on which reagents need to be bought and how to distribute those stuff. And because the tender process is based on the lowest bidder, the quality does not come into equation. Or on the flip side, because of who you know, you could price anything you want. So there are inherent flaws in public systems as far as use of resources, as far as use of talent, and as far as use of time. On the private side, we make those decisions in minutes to hours. We move resources, we negotiate price, we negotiate salaries in a way that allows the customer to pay. However, because we are incurring cost, the notion of free care does not exist in our lexicon. And so we are pretty much up against the global health agenda that says, Moka, how do you make your services to $1 per day? But if I do $1 per day and I'm seeing only 30 people, that is $30. I cannot sustain an operation on $30 a day. So really I as an entrepreneur in the market, I'm saying there are three markets we want to take care of. There is the bottom of the pyramid. That is the business of government, to use taxpayer collections to pay for services for the underserved and the poor. I don't see myself as having a role in that business. Then there is a high-end market, people who can pay anything in Kenya, and I would say their market is they do not even shop in Kenya. If they have a headache, they fly to London, they fly to India, they fly to Germany. That is not our market, and that is 3 to 5% of the market. Our market as entrepreneurs are the working poor who earn a living and are looking for value and can afford to pay a decent pay for service. And that market goes between people earning between $400 a month to, let's say, $2,000 a month, in that ballpark. And they're looking for deals, and that is the market we focus on. And I believe that is the role of enterprise, right? But the bottom of the pyramid is just become a tenderpreneur. Tender to the public sector, offer services while you have somebody in power, and you'll be very successful. There is a video that you can search online called COVID Millionaires. I encourage you to watch that, and you'd see how many people got rich because of COVID, and that will tell you how public systems work.
Thanks. Wilmot, do you have, what can you add to this? And then Steve, I'll come to you at the end.
Well, there's a lot there. Is there anything specifically? I saw a question in chat about logistics and distribution. That is an angle that Moka just touched upon. Should I touch upon that, or? Yeah, because a lot has been said already on that one. I don't.
Your experience with the Africa CDC,
Right.
You have had this, this experience of trying to build out public institutions or bolster in some respects. So I wonder if you can kind of bring that one.
So from that perspective, there are institutions like the CDC that have networks, right? They have educational training, they have relationships with 3PLs, third-party logistic companies, and then international partners that have their own logistic companies like the WHO, et cetera, et cetera. So it is fragmented, it is large, it's fragmented, and I think the challenge is to kind of rationalize it in such a way that more of the private sector gets involved and help create greater efficiency, because a lot of decisions are made bureaucratically, as you could imagine, by public institutions. And so the end user, the primary beneficiary, pays the consequence of that. But I will say also that with Zipline and other disruptions in technology using drones, we're seeing new opportunities to get blood transported to from hospitals to emergency scenes in rural areas. And so that technology disruption is helping a lot.
Steve, do you have anything to add to what you're seeing, especially as you kind of observed across the continent? If there is if you land on one side or the other of who's going to be responsible for providing health services or health provision,
Yeah, I think thank you. Moka raises some very good points, and it's difficult to dispute. Although we and I have a very different take on this. I do agree that an entrepreneurial solution to addressing needs at the base of the pyramid are very challenging, even when it is someone from within the base of the pyramid that seeks to provide a solution. So if we're looking at um, uh, an education strategy in one of the slums like Kibera, or health interventions in Kibera, whether it's an NGO or whether it's an entrepreneur from within that community, it's difficult to make work. I come at it from more of a capitalist perspective, and that is that uh, unless there's capacity in the country to begin with, uh, it doesn't really matter who you're trying to serve, the base of the pyramid, or reclaim the 2 or 3% who are going up to Dubai or to London for care. So my view is that the private sector's role and the role of private equity and venture investing is to create capacity, either expand what's there or initiate things that do not currently exist, and do so with a conviction towards impact, whereby you take very seriously the triple aim of healthcare, which is accessibility, affordability, and quality. And if you do that for your target population, and if you begin to emphasize how we're going to deal with accessibility and affordability, you can begin to embrace or bring into your system people at the base of the pyramid. So, you know, one of my heroes in life, and I have a whole bunch of them, is Dr. Devi Shetty in Bangalore, India, who created the Narayana health system, which provides absolute world-class quality cardiac surgery when needed, but they do not turn anyone away, no matter based on their ability to pay. And they do things through a very a somewhat elaborate system of determining needs and providing quality. So if I were to need care on one of my trips to Bangalore and I ended up at Narayana, I would pay top rupee for my care, and that would essentially subsidize other people in society. And I think you can have viable businesses when you take that approach. The only problem with that is it takes a while for those services to percolate up to or trickle down, whichever metaphor you want to use, to the base of the pyramid. And that's something we need to get a hold of. And that's one of the reasons why I think universal health coverage is going to change things. So as Wilmot knows from our colleague at Strathmore, Dr. Gilbert Coquaro, who's chairing the National Task Force on Universal Health Coverage, this is intended to be truly universal and provide access for Kenyans to both the public and the private sector providers. And that is potentially a game changer. And I think it's an important element. So.
Yeah, thanks. I was just grabbing my unmute. Thank you. Yeah. Wow. I think that's some really interesting perspectives from all over. But I think centrally saying that there is a solution that can be potentially made, but really that we need to be shining a light on the right things. And I think from Noelle's work that I actually was looking at this morning, a piece of that is that there just hasn't been sort of this kind of recognition of what some of the sort of pain points have been. So thanks for that. I wanted to hand over to the audience here. I see a couple questions. I have a question from Jordan about healthcare infrastructure and equipment distribution systems. I have a question from Trudy, or two questions from Trudy about changes. If you've seen, Moka's been in Africa for about a decade. I think Steve and Wilmot, you've been watching trends on this, Noelle, as well. I don't know if you have a potential answer to if, you know, since the Africa Rising narrative of 2010, if there's been a big shift in the way that people are focusing resources or building out health investments on the continent.
If there's something I can just lay down is one of the mistakes Americans and even to some extent Europeans make is we look at Africa as if it were a country, and it's really a continent of 54 countries. And I think all of us would agree that there is a very uneven pace of progress among African countries towards achieving better healthcare for people. So to answer many of the questions that are being posted, we either have to take a regional or a country approach to answering them.
Yeah, I think, you know what, I think the community here, this is basically probably we can speak to what's happening in Kenya and we can speak to what's happening in Tanzania, which have always had incredibly different development trajectories from independence, really, really drastically different national ideologies, and have always been a really great case study of the difference between what happened if you took a socialist approach versus a capitalist approach at independence. So I think, yeah, let's speak to the situation on the ground from the Tanzania and Kenyan perspective. Thank you, Steve.
Yeah, I'll say a couple of things. I do think that what we've been aided by now is over the last 6 months or so, refocusing on the importance of strong healthcare systems. I have been, and this is, you know, with good reason, kind of concerned that the limited partners are still kind of hesitant to pull the trigger on investing in healthcare. For example, what I mean by that, healthcare focused funds, sector focused funds. You know, there's, you know, both sides of the argument about risk management and diversification, et cetera. But the fact of the matter is, unless the private sector steps up in terms of investing, it's not going to get better. We cannot depend upon governments. We cannot depend upon even foundations to fill the gap with private capital. And so I'm hoping that next year, this time, we will see a lot more private investment going towards not just healthcare's focused funds, but just the healthcare sector overall. But what I will say in response to that question about infrastructure is that, you know, what we've seen here in Kenya over the last 6 months is innovation by necessity. By that I mean, where there hasn't been infrastructure, there has formal infrastructure. You've seen dukas, which are like, what's a good analogy? A corner store. Mm-hmm. Or I'm from the Midwest and we call them pony cakes. You know, you see those little depots, if you will. They even spread out, you know, outside the urban centers into some of the more rural areas, distributing, you know, PPE and helping along those lines. And so I think what we also have seen, just as you've seen across the world, is different enterprises now pivoting to make a difference. Whether, you know, it's a large manufacturer that does textiles here on the coast, the economic empowerment zones, now producing PPE, or if it's something else, it is happening. And so those infrastructure hurdles are being overcome, but this is short term. It's not sustainable, and it's not gonna be able to meet the need should the incidence of the virus grow and expand rapidly.
Yeah. Moka?
But one thing, I'm sorry, one thing I should say also, these are just recent conversations. So over the last 4 or 5 years, I got to know sovereign wealth funds pretty well. I wrote my PhD dissertation on them. And so what we now see is, this is not unfortunately in Kenya because there isn't an established one yet, but there's conversation. Places like Angola, FSDEA is now doing a deep dive and investing in healthcare among other sectors. But this is before before the pandemic, and I think we'll be seeing more of these what we should call state-driven capitalism. These efforts try to come in and fill this market failure, the void of more private capital going into healthcare. And I see the same thing happening in some of the funds in West Africa, and it's a big deal because that's a lot of money. It's billions of dollars in the case of Angola, and also the Nigerian Sovereign Investment Authority that can now mobilize and has to now mobilize some of those resources to support healthcare solutions in their countries.
Great, thanks. Okay.
Yeah. I'm going to jump in very quickly here. We operate in South Sudan and Kenya, and to the point that Stephen raised and Lindsay supported, those are very different markets. So I'll talk about them with that lens. Now in South Sudan, South Sudan is a market where there's still a net shortage of service providers. And so the public healthcare system is quite weak, I would say very fragile. And so the healthcare system is entirely dependent on private sector players like us coming to the market, taking a lot of risk in expectation for some return. Now, that market is challenged by a couple of structural issues whereby the cost of renting out the space, the cost of energy, the cost of internet and data already put a certain premium on the price of healthcare, regardless of how you spin the wheel. So of all of our facilities, the highest rent that we pay per month, fixed cost, is in South Sudan. So care there comes automatically at a premium. And so the value proposition from somebody seeking care is, do I want to pay a ticket to fly to Nairobi or Khartoum or Cairo? Or do I want to go to the private sector here? Or do I want to go to the public facility? And the public facility, I mean, talk about they have not released budgets and paid staff for 3 to 4 months. I don't know if anybody wants to go to a facility out of their own goodwill and volition where the staff have not been paid for 3 to 4 months, right? So, and then you have the issue of supply chain where everything is coming either from Uganda or Kenya. So everything is priced at a premium in that market or nothing. So it is a first mover market, and those who have moved in are doing reasonably well against challenges, obviously. Kenya, on the other hand, is a very different market. When I started in Kenya, there were roughly 3,500 public facilities and about 2,700 based on national statistics, private facilities. Right now, the pyramid has flipped on its head, whereby there are more private facilities than public facilities. So healthcare in Kenya right now, for all intents and purposes, is driven by the private sector providers. That is in part enabled because the private sector gives better wages than the public sector. So even if somebody is practicing in the public sector, they are using their practice, their presence in the public clinic to recruit patients to bring to their private clinic. So we believe in Kenya right now, at least I'm of the school of opinion, that it is the perfect market for private sector innovation to really help bring in more quality and bring in more, much faster service, if you will. I'm of that school of thought. Why? Because all the pillars are in place, or the environment is right for innovation. It is time where you have to differentiate yourself. Just having a door with a desk and putting a clinic sign does not guarantee people coming, because people have options, right? However, the challenge in the market like Kenya is that, who is your competitor? You realize that we are competing in many cases with the global health agenda in a very fundamental way. Malaria care is subsidized. Pregnancy and women's health care is subsidized. Reproductive health care is subsidized. HIV care is subsidized. And so people are always struggling between going to the free service or coming to the paid service for things that are of public health nature. And what that has created is that we as private providers, we have said, those conditions are conditions for government. We don't touch. So for example, our HIV caseload is limited. I don't think we do 3-4 patients of HIV a month. Maternal and child health, I don't think we do any deliveries per month, not because we don't have the capacity, but we start competing with government in that space, or donor subsidized initiatives. So Kenya is a market, and even on the pharmaceutical side, you hear patients come, well, your medicines are more expensive than when we get in the public dispensary. Yes, because it's subsidized by the government. But the government supply chain is unreliable, so they come to us. So we have that price dilution in the market, which makes it extremely difficult for private enterprise to really compete end-to-end and create a clear global health, a clear bucket of services, a bouquet of services. So we are now leaning heavily on the private insured market in order for us to survive, where that is now catering for 70% of our patients are privately insured, and then walk-ins is basically cherry picking. And so I kind of see the private sector becoming even more dominant post-COVID, because now we are addressing issues like logistics, we're addressing issues like teleconsultation, whereas the public system is not even ready for teleconsultation. The public system is not even ready to deliver medicines to homes. The private sector is already doing that. All major hospitals are now delivering medicines to home, doing mobile lab collection services, offering teleconsultation services, and the public sector is yet to respond. They are still putting up beds in case of an outbreak. So I think this pandemic is going to transform the market in a way that private would pretty much dominate the outpatient agenda in a market like Kenya, Tanzania, Uganda, until further notice. And then, you know, I think even in South Sudan, but that's sort of my feel. And I encourage anyone who has a disruptive approach to healthcare to really think about those markets right now.
Thanks, Moka. Hey, Noelle, one of the questions actually, in addition to if you've seen any trends or changes, it talks a bit about aid and where the funding is coming. And I wondered if you could speak to sort of trends and what you've seen in that as well. We know, you know, foreign aid trends ebb and flow based on donor, you know, desires and bilateral relations. Can you speak a bit to what you've seen?
Yeah, the policies that I really appreciated the comment about competing with the global health agenda, because I think that that's an aspect that people don't really understand. If you're talking about people anywhere, it seems like, oh, well, donors and aid, that's inherently a good thing, right? And the problem with it is that no matter who the donors are or who's providing that aid or investment, they have their own ideas about how they want that money spent. So we have a situation where all of these different players have signed on to various transnational policies, like the Paris agenda and the Accra agenda for action and the Busan development cooperation. All of these are talking about best practices that are the things that donors say that they're going to do, but then they don't do them. So donors prefer projects that they can, or particular problems that they can intervene upon, because it's easier to measure output and impact, right? Health system strengthening, you're not going to see the impact of that for years and years and years. So getting donors to they know in practice that it's better to do that because it creates more flexible systems that can deal with a COVID or an Ebola or, you know, the increase in obesity and hypertension or whatever it happens to be, but they're not interested in doing that. And this continues to be a conversation they keep having over and over again. But also those funds aren't sufficiently flexible because they are targeted. So in the hospitals where I have been seeing how this goes, you can get top-notch HIV care. You have the nicest furniture, you've got a TV outside that's on that you can watch while you're waiting for your care, very private consultations one-on-one where you're not crowded in a room with other people and having to tell your health information to others from your community while you're getting services, like all really high quality care. And they still had too much money for HIV, but they're required because it's targeted to spend it on HIV. So then they started building playgrounds for the kids of family members who are getting services at these hospitals because that's for AIDS too, right? And they started getting nicer furniture put in. And these are health facilities that don't have adequate supply of the essential medicines that the public sector says that they're going to provide to certain populations, such as pregnant women and elderly and people with HIV, et cetera, et cetera. Those essential drugs that are there for the ailments that the donors don't care about are constantly in shortage. And then, you know, you have this dilemma. They're supposed to get it for free. They know they're supposed to get it for free. They can't get it for free. And if there's an overage, the facilities are not allowed to spend money where they need it. They have to spend money where it's been earmarked by people outside. So there's no flexibility in that donor system because they're planning everything on this, you know, 5-year plan, and then they get together once a year and they talk about what their outputs were and this kind of thing. And that lack of flexibility means that even the public sector can't be nimble, but it doesn't mean that people working in the public sector aren't nimble. They're just not provided with opportunities to do that because everything's earmarked. So I think the whole way that whether it's bilaterals or multilaterals or foundations, like their way of thinking about everything in terms of, you know, we're going to do best practices of you know, results-based financing and this kind of thing. It's so restrictive that in the end, there's not enough ability for people on the ground to actually respond to the needs in a given period of time. And it's really problematic. And the issue that I have with it is they've all signed on to various agreements transnationally saying they're going to do health system strengthening. They're going to ensure country ownership of things. They're going to make sure that that they're coordinated and cooperating and they're mutually accountable to one another. And then they're just not. And there's no teeth. There's nothing to force any of these donor players into taking responsibility for the fact that they've signed on, agreeing to do this. And then the last thing I'll say about that before throwing it to everyone else is just a lot of times they keep doing the same thing they were doing before, but they call it something else. So they're doing the same kind of project-based support, but then I'm like, well, if we work on HIV, that's good for the whole system. So they don't change anything. They just make it look like in their pamphlets what they're doing is actually in line with what they signed on for, but in practice, it's not. And of course, looking at a report, no one can see that because they get to self-advertise, right? USAID is self-advertising their accomplishments. They're not going to sit there and give you a accountable, transparent understanding of what's going on, even if they were sending people to the ground to know what's happening, which they're not.
Yeah, thanks, Noelle. I mean, this comes up quite a bit with my students, but I think it's good for the audience to understand. For the majority of Africa, across Africa, Steve, for the majority of African history since independence, the public sector plus foreign aid / international development has been the dominant force for almost all of this type of public provision, not just healthcare, but education, etc. So it really has been a shift in the last 10, 20 years towards private. Even when there was a privatization move, like back in the 80s, it wasn't like successful. It's really been much more recently that we've got this critical eye that Noelle has shown of what actually this public donor-based approaches would have been the pitfalls of it, which is maybe what Moka's really discussing, which is a lack of innovation or a lack of a hustle mentality. The types of investments that you'd want to see just haven't been there. Wilmot's really coming up against continued fight to try to get people to make the kinds of investments that are going to kick out the system that Noelle, I think, is kind of claiming is pervasive and continues to be pervasive. I have a final question, or actually, I have a minute. So, let's end on a positive note. I like to do that. In one sentence or two, can you tell me what you're hopeful about in Africa health systems? And I'm just going to run down the line, and my line starts with Wilmot. What are you feeling hopeful about?
Sure. I think it is the innovation by necessity. I do think that we are seeing more young people engaged and owning their own future. By that I mean there is now more accelerator support, incubator support for healthcare focused early stage ventures than I've ever seen before. I think we're going to see more of those supported through the Africa Public Health Foundation. I do think that now we're seeing some pivot of angel investors focusing on that segment. So that's very, very hopeful. And I'm hopeful that also that things here in terms of the timing happen in some cases as an after effect. The stock markets, we've seen it with the pandemic as well. But the good thing is, I feel, it'd be interesting to hear what Moka and others think about this, that the government, the leaders here, the heads of states here, the ministries of health are trying to apply those lessons here in Kenya for sure. With social distancing, having to wear face coverings, understanding the importance of curfews. And I'm hopeful that because those messages in terms of what we're seeing across the world coming here and we're learning from them and trying to our best to kind of forestall disaster.
Moka, you're next.
Wow, I think what I'm hopeful and what is reality actually, and I'm saying this so that those who are thinking about systems innovation should really give some consideration to the South-South trade that is happening. With COVID pandemic, most of the procurement is now coming from the global South, China particularly. And China is offering services, equipment, and supplies at a fraction of the cost from the Western suppliers. For example, a PCR test from a major American company could cost you over $100,000 with $10,000 annual service fees, with $60 per test kit, making the kit available in the market at $80 to $90. The same services and infrastructure head-to-head from China, you're talking about $20,000, average kit, cost of kit $15. So that is creating a huge transition in the healthcare system in Africa across board, and I'm saying it at the continental level, where now you're having private clinics now being able to do what they were traditionally prevented from doing because of the barrier of entry or the cost of equipment and reagents. So diagnostics are now becoming more available. CT scans are happening in cities. MRIs are available, ultrasounds. So I am happy about that because it is allowing quality care and affordable care now to come into the market. And with that, the reality of universal healthcare becomes actually more realistic, whereby for the contributions that the public makes or private companies make into the universal healthcare equation, you can afford services at a price point that makes sense for all parties. So I'm very hopeful about that. The pandemic has opened up that door wide, and I think we would be seeing a reorganization in healthcare as we know it by 2021, 2022.
Thank you. Steve, it's to you. And before you talk, I just want to say thank you so much for jumping in today. We really appreciate it.
No, I hope I wasn't an interloper. I just,
No.
I think what I'm most hopeful about is that the munificent West which has long wanted to do the right thing, has had a very difficult time recognizing that Africans have always been ready to address their own needs. And it seems only now is the dialogue gotten to the point where we're rethinking what aid is all about and what infusion of capital means in the continent. And I think consistent with what Wilmot and Moka have been saying is we more and more need to move to indigenous creation of capacity and logistics, and also production of pharmaceuticals and devices. Yes, it is great that we can provide African laboratories with Chinese technology, but wouldn't it be great or better if we were producing those goods directly in Africa? And there's no reason why that can't happen. It may take a little while, but we have to really think about African countries as having fully integrated economies. And I think we're finally at that point where to the extent that capital flows from the West and from the global North continue, they're going to be for that purpose.
And finally, last but not least, and the first person on the webinar, Noelle.
Thanks. I really agree with what my fellow panelists have sort of pointed out here. And one of the things that I've seen that has given me a lot of hope for sort of wrestling people out of their preconceived notions about just about everything with this pandemic is the idea that, you know, there's a whole lot of interdependence that people took for granted they didn't realize was even an issue, and then suddenly COVID disrupted everything. Mm-hmm. And I think a lot of folks are rethinking what's possible and what the kinds of relationships that they want to be building and the kinds of capacity that's necessary at home and abroad, wherever they may live, because of that. And there are things that practitioners and entrepreneurs and scholars have been saying for decades and are necessary, and like no one's been listening to those particular things that we need to invest in, you know, the leadership and researcher capacity of Africans, and actually instead of just getting funding and then finding some collaborator in whatever the place in Africa is that we want to work, who's basically going to do the grunt work and get none of the glory, like realizing equity and equitable partnerships are really, they're really the foundation for all of these great things to be able to happen, and that ideas are not flowing in one direction. In fact, better ideas should be flowing from the ground on the way up and not vice versa. And I feel like this pandemic has made that pretty clear, because you have to be able to be nimble to context, and context is the one thing that's super inconvenient for planners. And that's what's needed. So I think that realization is hitting lots of people right now, and I'm thankful for it.
Great. Well, thank you all so much for taking the time. Again, to Steve, thanks for joining us. To Moka and Wilmot, I'm glad you guys were able to get in. You've given us lots of food for thought, and thanks to the attendees who hung on till the end. I really appreciate you taking your time to give us a glimpse into a very important sector, especially relevant today. So thank you so much.
Thank you.
Thank you.